We have two great sessions lined up for you. I'd just like to also say you can still visit the stands in the exhibition hall, though the treasure hunt has actually now finished. Please put any questions from these sessions or anything you'd like to know in the Q&A box that will be at the bottom of your screen, or any comments or questions. You can also use the chat function. So it's my great pleasure to introduce our first speaker, Jacqui Fletcher, OBE. She is a senior clinical advisor for the Stop the Pressure programme at NHSEI and is an independent wound care consultant and editor of Wounds UK. I'm really looking forward to this session. Pressure ulcer prevention, how much has it changed in the last 60 years? Welcome, Jacqui, over to you.
Thanks, Jo. I'll just share my screen if I can. There we go.
That's perfect. Thank you.
And it's a huge topic. 60 years doesn't seem like a huge amount of time, but actually a lot has changed. But I just want to go back a little bit further, because I think it's important to say that pressure ulcers are nothing new. We've heard some of the new things that have been happening around COVID from Joyce and other speakers today. But we know things like Florence Nightingale in the 1860s were talking about pressure ulcer prevention. And some of the quotes that are really well known from her are things like, if the patient has a bed sore, it's not the fault of the disease, but of the nursing. And I think this view continued. So this is a quote from a student nurse, Evelyn Matthias, and one of my colleagues found a notebook in a set of books. She bought a box of books at a car boot sale, and this student nurse had very carefully, neatly transcribed all her notes. And you can see what she's written about pressure ulcer prevention, that 9 out of 10 patients are at risk if they're on bed rest. But again, this kind of blame culture, they're a result of carelessness and neglect, and always a disgrace to the nurse. She talked about things that we would talk about: pressure and wrinkles, moisture increases the risk of bed sores, but they talk about friction in a positive way. What they're talking about here is massage, and that friction will prevent bed sores. She also mentioned the importance of egg white and oxygen. Now, that continued for an awful long time. So as a student nurse in the 80s, I can remember some of the sisters using egg white and oxygen to try and heal wounds. They had turning beds, something that we are now starting to relook at for patients who can't reposition themselves. Hopefully our beds don't look like this. This was quite a contraption where the patient was suspended above the bed on some webbing, and you turned handles alternate ways. And sometimes the patient was actually suspended face down between these straps. It can't have really been very pleasant for them. But they had the idea that you needed to reposition the patient and move the weight. We also saw some good physiology type work, and that 32 millimeters of mercury that we're all very familiar with comes from work done in the late 1920s, early 1930s from Landis, who looked at capillary blood pressure in human skin. And categorization, one of the topics close to my heart. There's a German student's dissertation thesis that talked about two types of decubitus: superficial wounds resembling abrasions and those deep and necrotic ulcers. So very much talking about the things we started to think now about, are the two different types of pressure ulcers? Are they some that start near the skin and some that start close to the bone? So let's get on to this 60 years worth. Well, for me, the last 60 years starts in 1962 with the Norton score. And I've done a quick timeline, just putting on some of the things that I think are important in that time. There's obviously many, many more things, but for me, important things: TVS was formed in 1979. I think we need to acknowledge that. My first memory of a pressure ulcer prevention policy, and I think it was probably one of the first in the UK, was the one for City and Hackney Health Authority. And the first national guidelines that I was aware of were those designed in 1992 by the Americans, which is then the Agency for Healthcare Policy and Research. Here in the UK, things moved on a little bit in the early 1990s, where King's Fund designed some standards. And we had some acknowledgement from the Departments of Health that this was a problem, where they defined pressure ulcers as a key quality indicator. So they were saying that pressure ulcers were not just a harm to the patient, but they related to the care that was delivered. Not very much happened for a little while. We had the formation of the European Pressure Ulcer Advisory Panel, a really seminal event for those of us in Europe. And, it's something that I remember very clearly. A small group of us sat in a room in Oxford with a flip chart, trying to decide if this was worthwhile doing and what we would do and what the purpose would be and how it would all work. And I'm delighted to see that it's still going strong now. On a policy level in the UK, in 2010, pressure ulcers were once again identified as a harm with the Quality, Innovation, Productivity and Prevention Programme, and also named in the high impact actions. So raising the profile of what pressure ulcer prevention should be and why it's important. 2011, locally and in my region in the east of England and later in the Midlands and East, Ruth May, who's now our chief nurse for England, but was then the regional chief nurse, started the Stop the Pressure initiative. And that was a really important action because it led to a huge amount of quality improvement activity across the whole of the middle of England. And it was also important in triggering the patient safety thermometer and the sequin, the associated quality payment that went alongside that. 2014 was a really big year for guidance. We had the NICE guidance issued, and also the first, most recent iteration of the international guidelines led by the Americans, Europeans, and the Pan-Pacific Group. There was a little hiatus in what happened then in the UK, but when Ruth moved to the chief nurse for Monitor, she restarted the Stop the Pressure programme as a national initiative. And again, we saw this focus on pressure ulcer prevention being a national programme. Once the programme was in place, we started to see new documents being put in place, new quality improvement things being put in place. So we'd had the sequence and they finished. We then had a framework for defining and measuring things, started to try and standardise the language, get us measuring the same things, the national curriculum, so to put a framework together for education. We did a huge audit across 2018 and 2019, more than 10,000 patients were surveyed, not just for a prevalence of pressure ulcers, but to look at the quality of care that went into that. So using the asking bundle, what things were being done for them and what things were being missed out. We had the update of the international guidelines in 2019. We provided a new categorisation tool in 2020, and then everything kind of paused, as most things do, to focus on COVID. The pressure ulcer resources were related to COVID. They were around preventing staff developing pressure ulcers under PPE. They were around proning, and Joyce just talked an awful lot and very eloquently about what we do around proning patients and some of the challenges that we have for that. So that's a really quick run through the 60 years, but I want to pick up on a couple of things that I think are quite important and maybe not well understood. And one of them is about the Norton score, and we're quite dismissive of the Norton score now as being of its time and wasn't well researched maybe, and we've got better and different things now. But actually, if you look at the Norton score and what Doreen Norton did, she was a phenomenal researcher, particularly for her time. And she wrote a paper in 1989 reflecting on how she put the score together and what she would change if she could. And when she talked about the context of designing that score in the early 1960s, what she said was that the main emphasis was on attention to the skin. And the way we cared for skin was that there was this very strict 4-hourly regimen. There was the bed bath round, you took this trolley round, and you had soap that you lathered up, and you let it dry on the skin, and then you put white spirit on the skin to dry it and harden it. And then you coated that with talc. The talc, again, dried it a bit more, but it also changed the friction of the surface. We were starting to see some equipment. So we had the small cell ripple mattresses. If you have never seen a small cell ripple mattress, it's about this deep, an inch maximum. It really makes you wonder what difference that made to a patient. We had Sorbo cushions for in the car. And she also explained, and to be honest, I never knew this. I've always wondered why the Norton score, the lower the score, the higher the risk. And she said that the descending score was chosen to correspond with a decline in the patient's condition. And that's primarily what Doreen Norton is known for, but actually she remained very involved in pressure ulcer research. One of her reflections talked about the change in the way we research, and she was able to say that in a way, she was very fortunate because of the time she did it. They were allowed to watch patients and allow them to go on to the point where they developed a pressure ulcer to see if the score was accurate. And she wrote that she remembered how stressful it was not being able to intervene until the evidence was conclusive, that the existing preventative measures were ineffective and lesions highly probable. Now, we wouldn't be allowed to do that these days. We just wouldn't be allowed to do it. And those kind of 20 years later, she was saying she's so glad that things have changed. But actually, in terms of research and scores, we know that one of the biggest challenges we have is we can't talk about the predictive value of scores because we intervene and that changes it. She was very involved for many years, and she carried on to look at the use of equipment, and she travelled as a researcher, and she went to the States, and she was very negative about some of the changes she saw in the equipment, particularly the new beds were coming through where you could lift the backrest. It was part of the bed frame and you could lift it, because her immediate reaction was that must increase shearing forces over the sacral area. So all the things we are now talking about well, you elevate the backrest, she was talking about back then. And she'd been part of the team that designed the British standard for the hospital bed in 1966. So those of you who've been around for a little longer, certainly into the 80s and early 90s, will remember the old King's Fund beds. And these were a solid, flat bed base. And the backrest came out from the head of the bed, and you had to kind of squeeze a lever and do this rattling to make it come out and prop it up with pillows. But she didn't want this rising back facility because it caused rooking of the mattress cover and the patient's sheet right across the pelvic area, the area that the patient was most at risk in. So in the 70s, late 60s, early 70s, we saw some movement in equipment with Mary Bliss and Norman Exton Smith, both from Barts, looking at a larger cell ripple mattress. And that was the precursor, the predecessor to the alternating systems that are still in use now. 1976 saw one of the first multidisciplinary conferences around the prevention of bed sores, and it's called Bed Sore Biomechanics, and had names there you will be very familiar with if you know anything of the history of pressure ulcer prevention: Joe Barbanel, John Scales, and others. And I think it's important to look at what they talked about, because it's exactly what we're talking about now. It was about physiology, it was about cost and economics, it was getting the biomechanical engineers involved exactly as we're doing now, and designing patient support. And this is where the Reswick and Rogers curve that we'll be familiar with about time and pressure comes from. The book is really interesting in itself. There are some fabulous pieces of equipment, and I'd like to draw your attention to this patient in a plaster of Paris bed. And you can see what they're trying to do is increase the surface area in contact. So they've made a total body contact cast. But I dread to think about the high points of pressure behind the patient's arm and where that cast stops at the mid-calf. But if you look at the diagram underneath it and what they're talking about the different materials, they're talking about the points of high friction, they're talking about how they're trying to ameliorate those things. I mentioned in the late 1970s, we had TBS starting, and it came from a rehab perspective. So again, lots of people very involved in active rehabilitation of patients, and then becoming a national society the next year and gaining charitable status in the 1990s. The next big piece of research, I think, is probably that from Judy Waterlow, looking at the Waterlow risk assessment tool. And she talked about, as at her background, that in 1977, the Department of Health and Social Services had costed the treatment of pressure ulcers at £100 million, and that had probably trebled by the time she looked at it. So in her small hospital in Taunton, she surveyed patients both in hospital and community and did a prevalence study, got quite low prevalence. But based on that, she designed a new tool, which she did an evaluation over 4 weeks, looking at patients on admission and then every 3 days. Differently from the prevalence, she examined all the patient's skin herself, which probably explains why she found a much higher prevalence of 17%. And this is the card that most of you are probably familiar with. So we've had various iterations of it, but what Judy really felt was important with the card, it wasn't just the front, it was the back. And on the back, there was a pressure ulcer prevention protocol. It kind of told you what to do depending on the level of risk. And you can see in the bottom one, the most recent 2005 one, some real changes around special risk factors, about body mass index and nutrition. Also in the 1980s, we saw some more work coming out of Barts from the then chief nurse, Pam Hibbs, who unfortunately died earlier this year. And Pam was really interested in the cost of pressure ulcers. And just at the bottom of the screen, you can see I've highlighted there that they were in a period of financial difficulty. And I thought it's important to say that because we always feel we're in a period of financial difficulty. But this is where those original costings of how much does a pressure ulcer cost. And she followed a patient who was in for 180 days with a total cost of nearly £26,000 for caring for that patient. And what's really important about this work is if you look at the papers she wrote, is she broke it down. And she didn't just look at nursing costs, she looked at medical costs, paramedics, physiotherapists, equipment hire, and a whole host of other things. But in that research, she also talked about opportunity cost. And this is something we use a lot now when we're talking about economics. If we didn't spend the money on that care of that patient with a preventable harm, what else could we do? She also talked about the essentials for a pressure ulcer prevention programme. And the first point she makes is about research-based practice being carried out by every member of staff. She talks about education and this focus particularly on the elderly and the paraplegics and the unconscious. She also starts to put together the resources that you'd require if you're going to do prevention in a district. And yes, there's that special equipment there. So, when I worked at Barts, this is the equipment we had. We had Spencos, we had Pegasus, the yellow Pegasus, and we had the Clinitron beds. They were only ever called the Clinitron beds, and what we meant were the air fluidized. But she also said we should be replacing the standard hospital mattress. And you can see there, she's costed a mattress replacement programme. But she also talked about that we need to think about the quality of care, and that if you are measuring the impact of what you're doing, you should be looking not just at the outcome of care, but the standard of the care that was delivered to achieve that outcome and the acceptability of the care by the individual receiving it. So she was very focused on the patient. So when I started as a tissue viability nurse in the 1990s, this is the kind of thing that I saw. Bed bases were solid metal, there was no ventilation. We had the old lovely marble covers, which were hard plastic that frequently delaminated, so that when you unzipped them, and even before you unzipped them, you could see the mould and inside on the foam. You could see what we hoped was just urine stains, but we know it was frequently other things. And if you ever unzipped one of those mattresses, and I unzipped every single one in my hospital, the smell was appalling. So my first role as a TVN was to put together a pressure ulcer prevention policy. I reread it this week. I'm actually quite proud of what's in that policy. It was based on these 9 standards. And as you can see, I've mapped them to the current asking. And it maps quite well. What seems to be missing is incontinence, but actually that's described quite well in skincare. And when you go through each of those standards that we talked about, there's detail behind it. So if you look at risk assessment, we weren't saying any different to what we say today. It should be carried out by a qualified nurse. They should have been trained. You should document it properly and sign it and time it. You should set a review date. And there should be a plan of care that's based on the risk factors. Here you can see the same for skin, very much talking about checking the skin, paying attention to the risk areas, keeping it free from damaging substances, don't rub it, and do things like use barrier creams to protect the skin. We've got a statement in there about avoiding the plastic and draw sheets, which we don't have in place anymore, but they were very common. And we knew how they increased the moisture and the temperature at the area. And a very important thing to me, and still important to me, is that when handling patients, we shouldn't be damaging their skin. So that rings and watches and long nails should not be there. The teaching we did was very similar to now, covered top to bottom and included pressure ulcer stages. It looked at the Reswick and Rogers curve. We knew about pressure, shear and friction, and we were able to distinguish between intrinsic and extrinsic factors. We used our policies to help guide resource use. So you can see here we have across the top the risk categories and down the left the mattresses we have. And there was also guidance that if there was more than 2 you could use, the factors that you might use to differentiate between them. We primarily used the Waterloo score. It was still quite new and quite exciting, but our way we displayed it was not very helpful. So we really just made it black and white and reproduced it in the documentation. And what you can see here is if you tried to follow the progress of this patient, you really can't tell if the score has got lower or higher or changed or what made it change. So one of the first things we did was change that into a tabulated form so that you had all the risk factors down one side and then a table that you put the data on. You could actually identify where risk factors were changing and what the total was at any point in time. So that kind of brings us up to this century and what's happened this century. And I've really clumped it all together because I think this century, what we've had is just a lot more of the same and more, and in some cases, much more, too much more of everything. We've got far more mattresses and other equipment than anybody can sensibly make a decision about. Our bed frames have changed significantly. We've gone from the static bed frames to the electronic profiling bed frames. I don't know that the bed frames have kept up with the patients. Patients have got much taller and much wider, and certainly our bed frames don't seem to have changed in size significantly. We've got far more dressings than we need to know what to do with, over 90 risk assessment tools, but not many of them based on evidence, more categorization systems. We have improved our level of research. But there have been some significant changes, and for me, the things that are really important and that have made a difference are the changes in our knowledge and understanding. So this is from the originally 2014 and later 2019 guidelines, talking about the etiology of pressure ulcers, a systematic review of what we understand to be the risk factors and pulling out the things that really make a difference. And that's led to tools like the Purpose T that's based on the things we know that actually indicate risk. It very much mimics what we used to call intrinsic and extrinsic factors, but it's just laid out better and based on evidence. Our biomechanical engineer colleagues have helped us to understand what's happening in terms of deformation-induced damage. So we talked about pressure and shear without really understanding at a cellular level what that meant. And now we're starting to be able to pull that together and think about how we may manage that.
1 minute, Jacqui.
The Reswick and Rogers curve has been revisited. So we now have the Geffen curve, again talking about high pressures for low time and low pressures for high time. But built on top of that, we're talking about deformation damage and how that causes harm much more quickly and that inflammatory response. But what's important is when all these join together, we have this cumulative damage. So in terms of the future, what do I think we'll be seeing? I think we'll see a lot more digital use, linked technologies, mattresses that link to smartphones that tell us when to turn patients, that the patient hasn't been turned, that the pressures are wrong, smart fabrics and materials that tell us about that, maybe the temperature and about the moisture levels. Hopefully are focused on healing pressure ulcers. That'd be really good as far as I'm concerned. And very importantly, better understanding and engagement from the general public. But for me, and on my final slide about what has changed is a little bit about where the blame and where the appropriateness of pressure ulcer prevention should be. So from that thing from Florence Nightingale about it's the fault of the nursing, to an understanding and an acceptance from clinical colleagues that every contact counts. It's not just nurses who are responsible for pressure ulcer prevention. It's physios and doctors and OTs and dietitians and podiatrists and speech and language therapists and paramedics. Everybody who sees the patient and who works for the NHS should be aware of and working towards preventing pressure ulcers. Thank you very much.
Thanks, Jacqui. Fantastic presentation. Did feel a little bit old with the King's Funds beds and the Spenco mattresses, but hey ho. Right, so on to our next speaker. I have the pleasure of introducing Dimitri Beeckman, and Dimitri is a professor of nursing science. He's president of both the UPUAP and the International Skin Tear Advisory Panel, and he's going to talk today on skin tears and the latest evidence. Welcome, Dimitri, over to you.
Thank you very much, Joanna. And thank you to TVS for inviting me today to present on skin tears. Thank you, Jacqui, for your excellent presentation. It's nice to see the overview and the historical overview of pressure injuries, pressure ulcers. So that was a great lecture. Since yesterday, I'm not the president anymore of ISTEP, so I'm the immediate past president. So yesterday, I handed over to my colleague, Jan Kottner, but I'm still the president of the International Skin Tear Advisory Panel. So what I'm going to present today is the latest evidence and guidance around this clinical topic. And on my first slide, you can see two best practice documents that we published, that were published by Wounds International in collaboration with the International Skin Tear Advisory Panel. One document, a best practice document in 2018 about prevention and management in the aged skin, and one document, a recent document from 2020 about holistic strategies to promote and to maintain skin integrity. So as a kickoff, I will start with providing an update on the definition. So what is a skin tear? It's a traumatic wound caused by mechanical forces. And in next slide, I will introduce you to the concept of what actually a mechanical force is doing in the skin and what's actually happening in the skin and the different tissue layers. It also includes the removal of adhesives. The severity of a skin tear may vary by depth, but it is important to remember that it does not extend to the subcutaneous layers. It's reported across all healthcare settings, and it is predominantly found in the extremes of age, being the neonatal population and the elderly, also critically ill and chronically ill patients. And in terms of locations on the body, it is particularly common on the upper and on the lower extremities, 50 to 80% on the upper extremities and up to 60% on the lower extremities. So what do we know about the size of the problem? Well, we can see an important variation in terms of figures, both at the level of prevalence and incidence. So I'm not going to read all these figures, but I think it's clear that skin tears, they are not a marginal problem. So they occur very, very frequently. We also have to realize that they are under-recognized and even under-reported. One of my PhD students who is defending in the near future, she found a prevalence of 12% in the nursing home population. So this figure gives you an overview of prevalence, but also incidence. The highest incidence of skin tears is found in the long-term care facilities. So that's about the impact. I would like to give you some updates about classification as well, because a lot of research has been done the last few years in terms of classification. There are several classifications available. The two most used classification systems are those of the International Skin Tear Advisory Panel, ISTEP, so that's the ISTEP classification system. And the other one is the STAR classification system from Australia. We both did a systematic review, and we also further developed and validated the International Skin Tear Advisory Panel classification system in 44 countries. We published this research in the British Journal of Dermatology and the International Journal of Nursing Studies. And so I'm just going to give you in a nutshell what we found in these studies. So in the systematic review, we found out that only the STAR and the ISTEP classification system were validated. So that means both tested in terms of reliability and validity. Most of the research was found around the ISTEP classification system. In the the study that we performed about psychometric properties in 44 countries, we found that the reliability is high, the reliability of the ISTEP classification system. So that means that there is a high inter and inter-rater reliability when raters, clinicians are evaluating, classifying pictures of skin tears. On the right-hand side of this slide, you can see the three different types of the ISTEP classification system. So the type 1 is no skin loss. It's more like a linear flap. A type 2 is a partial flap loss. So that means that there is a flap, but that flap cannot be repositioned fully to cover the wound bed. So there is a part of the wound bed that is still uncovered. And then the third type is total flap loss. That means that the entire wound bed is exposed. So that's the classification system. It is very simple. It's very easy to use. In the studies, we also had additional consensus about what a flap means, because a flap in the area of skin tears is different from a flap that is, for example, used for surgical skin grafting. So we had a lot of discussions and we found consensus about that definition. So a flap in skin tears is defined as a portion of the skin, being epidermis, dermis, or both, that is unintentionally separated from its original place due to a mechanical force, which can be shearing, friction, and/or a blunt force. And again, the concept of a skin flap is not to be confused with tissue that is intentionally detached from its place of origin for example, therapeutic use, like, for example, in the surgical skin graft. So that's an important discussion that we had, and I think an important update of the classification system. So what do we know about the etiology? Well, as I mentioned before, mechanical factors being shearing, friction, blunt trauma, falls, poor positioning, transferring techniques, the use of equipment, the removal of adherent dressing. So these are all the mechanical forces that cause the development of a skin tear. The epidermis is separated from the dermis. So that means there is a partial thickness wound, or both the epidermis and the dermis are separated. Okay, so there is a difference in depth. So partial thickness versus full thickness. Partial thickness skin versus full thickness skin. And as I mentioned before, there is a relation between skin tear risk and age. Both neonates, children, and elderly or older people are at higher risk. And there are different reasons. For example, for neonates, we observe significantly fewer layers of stratum corneum, which is so important in the strength of our skin, less collagen, less elastic fibers, an increased transepidermal water loss, so associated with a decreased barrier function, a decreased cohesion between the epidermis and the dermis. So there are several reasons why neonates are at higher risk for the development of skin tearing. And in older individuals, we can observe a loss of collagen, elastin, the epidermis becomes thinner, there is loss of dermal and subcutaneous tissue. We also observe a reduction in the proliferation of keratinocytes. There is the flattening of the dermo-epidermal junction. The content of the natural moisturizing factor, or the NMF, reduces. And there are several other reasons why older individuals are at higher risk. So this brings us in the area of prevention. The International Skin Tear Advisory Panel was established 10 years ago, and we were very grateful to the founding mothers in this case. One of them being Kimberly LeBlanc. She is a PhD trained nurse, and she did a lot of research on risk factors and the development of pathways for both prevention and treatment for skin tears. It all starts with identification of risk. For skin tears, we don't have a risk assessment tool, as we have over 90, as presented by Jacqui, for pressure injury or pressure ulcers. So what she developed is a pathway, including the assessment of the general health, being the presence of chronic critical disease, polypharmacy, impaired cognitive status, sensory problems, visual problems, nutrition, auditory problems, etc. Then there is the mobility. As I mentioned before, falls is a major risk factor. The history of falls, the reduction in the mobility, being dependent for the activities of daily living, mechanical trauma, etc. And then, of course, there is the skin itself, the extremes of age, as I mentioned before, fragile skin, and the previous skin tears. Based on this analysis of both the general health, the mobility, and the skin, you can make a risk profile, being no risk, and then reassessment with every change of status is important. And this system defines two levels of risk, so being at risk or being at high risk. So that means if you are suffering from at least one of the previous risk factor, clinician, your family should consider you to be at risk. If there is additional visual impairment, impaired mobility, being dependent for ADL, extremes of age, etc., then you are to be considered to be at high risk. In that case, being at risk or at high risk means implementing a skin tear reduction program. And for this, I would like to refer to the iStep Quick Reference Guide. Comprehensive documentation, the implementation of tailored preventative care, and of course, the use of international evidence-based best practices. So I tried to summarize the major preventative strategies. As for every other skin problem, wounds being acute or chronic, we need the input of a multidisciplinary or interdisciplinary team approach. Patient empowerment, empowerment of families, caregivers to be actively engaged in prevention. The application of skin-friendly dressings, the use of skin-friendly removal techniques. So non-adherent silicone mesh dressings, for example, or silicone foam dressings, they can be applied. Be very careful when applying hoists and glide sheets. We recommend the use of protective clothing, padding on equipment and furniture, as you can see on the pictures on the slide. Fall prevention, and again, I'm referring to the interdisciplinary team approach. Avoid sharp fingernails and jewelry. So this is not rocket science. This is just high quality care that should be delivered. And this is an example of a patient that was lying on this device. So hoists and gliding sheets should be considered very carefully, okay? Because as you can see on this picture, this patient is really suffering from skin damage because of the incorrect use and incorrect transferring techniques. At a more general level, we recommend a structured, individualized skincare regimen approach, avoiding traditional water and soap washing, specifically alkaline soap, because of the impact on the pH, because of the impact on the dryness of the skin. Avoid excessive washing, and again, related to skin dryness. Minimize the frequency of bathing, apply water that has a lukewarm temperature, pat the skin dry with a soft towel. Cleansing to be followed by the application of what we call leave-on products. Leave-on products means the application of, for example, skin barrier creams or skin barrier products. Moisturizing, so there is an important Australian study that shows the effectiveness and the contribution of twice daily moisturizing of the skin. And then the emollient therapy. And again, dry skin, frail skin is an important risk factor. So what do we know about treatment? And this is a pathway that ISTEP developed under the leadership of Kim LeBlanc and her group. It starts, of course, with a skin tear. We need to control the bleeding. After controlling of the bleeding, we have to assess, we have to cleanse, we have to try to approximate the wound edges. And at that point, we can classify, not before, because the classification, remember, it's about type 1, type 2, and type 3. So only after approximation of the wound edges, we are able to assess and to document the full extent of the damage that has been involved. Then we have to set the goals of the treatment by treating the cause, focusing on prevention, focusing on moist wound healing, avoiding additional trauma, pain control, etc. And on this picture, you can see very visual how the approximation of the wound edges can be done. So we do not recommend the use of forceps because that skin, that flap is very, very fragile. We want to keep it intact as much as possible. So that's why we recommend the use of a cotton wool stick to re-approximate or to approximate the wound edges. So what else do we recommend in terms of treatment? Do not add new risk for trauma. Assess the comorbidities like venous disease, arterial disease, additional pressure, and then make a selection of a dressing. So after cleansing, we have to apply something to further protect the damage. Decrease the trauma. The dressing should provide moist wound healing, manage pain, and if possible, being transparent to allow wound observation. I briefly discussed about the skin flap. The skin flap is actually a biological dressing. So the more the skin flap, the viable skin flap that we can approximate, that we can use in the treatment of the skin tear, the better. But if the skin flap is present but not viable, it may need to be debrided or it may to be removed. But we need to be careful. When doing the debridement or the removal, we have to ensure that the viable skin flap is left intact and that also the fragile skin is further protected. This is an example of the importance of indicating how to remove a dressing. So if the dressing is not transparent, we just have to indicate, for example, with an arrow on how to remove it, because the flap is very fragile. We want to keep it intact also after the removal of the dressing. So this is about documentation and also about communication with your colleagues. So what about hydrocolloid dressings? Well, I will be very brief. They have a very strong adhesive component, and they have been reported to contribute to both medical adhesive related skin tears. So in the management of skin tears, we do not recommend the use of hydrocolloids because the strong adhesive components. The same goes for skin closure strips, and they're still used quite often in the emergency department. So we do not recommend the use of skin closure strips. What we do recommend, if possible, is, for example, skin glue. So topical skin glue, it's faster in the application, and also it will lead to better scar management compared to skin closure strips and compared to sutures. Lower leg edema is well documented to contribute to the delay of skin tear healing. So that should be covered as well by compression therapy. And when skin tears occur on the lower limb, the risk and the cause of potential peripheral edema should be further assessed. I also want to relate to the COVID situation. Proning and skin tears are related. One of my PhD students in Ghent is currently doing research on the link between proning and skin health. So she's focusing on pressure injuries or pressure ulcers. She's focusing on skin tears, on moisture-associated skin damage, etc. We know that proning or prone ventilation is an effective therapy for acute respiratory distress syndrome because it will improve the gas oxygenation and the gas exchange. However, we also know that proning and the prone position is not without harm for the skin. There is a risk for tissue damage. As I mentioned before, we've got the vulnerable pressure points, and they are indicated with the green dot. We've got the risk for medical device-related pressure ulcers. We've got the risk for moisture-associated skin damage, including incontinence-associated dermatitis, and also skin tearing. Adhesives, mechanical forces during positioning and during repositioning, during the transfer of the patient. So that puts that particular patient at high risk. As I mentioned in my first slide, we produced a document about holistic skin management and skin care, because actually those patients, they have a combined risk. So they are at risk for skin tearing, they are at risk for MASD, they are at risk for pressure injury. MASD risk caused by secretions will also have an impact on the risk for skin tearing. So we need to stop thinking in silos. We really have to consider risk factors into a very holistic approach. We developed a document, and that document is available on our website, so the Skint website, where we make very practical recommendations about how to prone and how to care for the skin. So what we recommend is a trained and experienced prone team to assist with the prone maneuver and to implement tissue damage preventative strategies. For pressure injury, it's pressure redistribution, and Jacqui, she gave a very good explanation and a very good overview of what is available and how the research and how the new technologies are contributing to better quality of care. Positioning is very important. So we recommend the patient in the swimming or a freestyle position, where we ask clinicians to keep an eye on the position of the arm to avoid the brachial plexus injury. Repositioning should be done every 2 to 4 hourly. That's why we need a specialized team members, for example, physiotherapists. We also recommend the application and the protection of high-risk areas for skin tears. That's why we recommend the application of multi-layered silicone adhesive foam dressings to cover those pressure points that are at risk for skin damage. So I only had 20 minutes for this presentation to give you an overview of the evidence and well, some latest information. So this was really a high level helicopter perspective of what we currently know. So just some final thoughts. There is the aging population. There is the increased prevalence of chronic conditions that will impact the risk factors towards skin tear development. More patients will benefit from early and accurate identification and classification, comprehensive documentation, treatment, and effective prevention. And although there has been an increased focus on the issue of skin tears the last years by, for example, TVS, in collaboration with the International Skin Tear Advisory Panel, and we are very happy that we have a close collaboration and a partnership now, there are still gaps in our knowledge and understanding and in the awareness. And we identify a number of areas for future research. And with this being said, I would like to thank you for listening to this presentation, and I'm ready to answer some of your questions. Thank you.
Thank you, Dimitri. That was a really good overview of the evidence there. And there are a couple of questions in the chat. Sharon has got one for you, Dimitri. How do you think we can change the culture of skin closure strips in ED departments?
That's an implementation question, and implementation is always a challenge. I think it all starts with proper training. It starts with showing cases where skin strips have been used and where they actually did not lead to the outcome that was expected. So really confronting them with the impact that skin closure strips can have on wound healing and scar management. So I think that could be one of the strategies, is just showing the impact of this treatment. So I think that could be one of the many potential strategies to change that practice.
And again, do you think early compression, if suitable, is useful in lower limb skin tear management in older people? Yes,
I think so. Absolutely. Yeah. So it's shown that lower limb problems and edema, they are a significant risk factor, not only for skin tears, but for so many other wounds. So early compression is useful, absolutely.
Kate, do you have anything?
Sorry, the idea of a risk assessment in care homes is, particularly nursing homes, would be fabulous. Do you think we're a long way from that, or
is that a question for Jacqui or for me about skin tears or pressure injuries?
Skin tears.
Oh, skin tears. Yeah, of course, because we've got many pressure ulcer risk assessments. Too many. Well, to be honest, I'm not a big believer of risk assessment tools. Well, I'm a believer, of course, of an approach and a tool to guide clinicians in their risk assessment. So that means training them in risk factors. So I've got a little bit more problems in attaching scores to that and focusing on cut-off values, etc., because that makes care, of course, a little bit more easy to perform and to do, but it's not always the most valid way and the most correct and accurate way to identify risk. So for me, this is really about teaching and training them in identification of those risk factors, both intrinsic and extrinsic, giving them guidance, good guidance. But I don't think that we need to go the same way as we had for pressure ulcers by developing cut-off values and scoring systems. So I'm not a big fan of that.
I think it just would confuse matters, wouldn't it? It'd just be another score and counting many of the same factors that we count.
Mm-hmm.
Yeah, definitely. Yeah.
I was thinking, Jacqui, it was so fascinating listening to your presentation. And there's so many common themes throughout history. Do you think there's anything we're still missing, or we just need to implement what we already know?
I think there's quite a lot of things that we still don't know, or we're finding out more things as we go. You know, one of the biggest challenges for me is engaging the public, and I don't think we know how to do that well, because the number of patients that we get, you've already got pressure damage, is a significant problem. In healthcare settings, we're doing well, we're reducing numbers, you know, we've had the blip with COVID. but we've seen that we can make things better. We can't make them completely better, but it's about the patients who come to us with pressure damage. And the only way we can improve that is by public awareness. And I don't think we've got that right by any stretch. And it'd be the same with skin tears, wouldn't it, Dimitri? You know, it's fine if they're in health, if they're being cared for, but it's the patients who aren't. It's the frail patients who are well enough to manage on their own, but come to us and they deteriorate.
Thank you so much for thank you so much, Jacqui and Dimitri. I'm going to close the session there. There are some more questions in the chat box. If you would like to take those onto the discussion forum and discuss those outside of this session, that would be great. So thanks again, and we're back. We're having a 10-minute break now. We're back at 4:30 for the final sessions, and that's the past, the present and the future, and it's about motivation. So we'll see you in 10 minutes. Thanks a lot, everybody.
Thank you. Bye-bye.
Bye.
Bye.